جلسات إن شاء الله. الجلسة الأولى diagnostic، الجلسة الثانية intervention، الجلسة مع أشياء أخرى. الجلسة الثالثة surgical، الجلسة الرابعة post operative care. هيك ترتيب الجلسات. بدنا نبلش إن شاء الله هلا لأنه عشان الوقت تايت عشان صلاة الجمعة، وقت صلاة الجمعة. فنرحب بالجميع البانلست دكتور حمزة المومني، دكتورة منتهى عبدالحميد، دكتور محمود عباد راح يقدموا لنا السيشن الأولى.
We'll start our first cardiology session. We'll start first speaker, Dr. Layla Totunji. Dr. Layla Totunji, consultant pediatric cardiology and fetal cardiography. In Jordan, she worked in Jordan-University Hospital. Welcome, Dr.
Thank you very much. Sabah al-Khair, good morning. I'm honored to be here today. Thank you very much for the invitation. Thank you for everyone who came early on a Friday morning. So we're going to talk today about seeing before birth, the prenatal cardiac diagnostic revolution. It's going to be a quick and sweet overview of advances and future directions of fetal echocardiography. So fetal echocardiography has transformed congenital heart disease from a postnatal surprise to the parents and to the healthcare system into a prenatal diagnosis with actionable insights, with preparation of everything for the newborn baby, including readiness of the healthcare system, referral to tertiary centers, and counseling for the parents reaching some kind of a closure before the baby is born. So why does this matter? Congenital heart disease is the most common congenital anomaly in humans, and it constitutes about 8 cases per 1,000 live births globally. However, in the MENA, and we saw this consistently over many studies, the incidence is about 15 per 1,000 live births. This is data from Jordan, from Palestine, from Lebanon, from Turkey, from Iran. Consistently, anywhere between 14 to 15 per 1,000 live births. We don't know why our patient population has almost doubled the global incidence of congenital heart disease, but we speculate that it could be due to the higher levels of consanguinity on the one hand, and perhaps the lack of folic acid fortification in wheat on the other hand. But it is an area for research. So looking at the revolution mindset and how we went from anatomy to prediction to intervention, and then we're going to have more advanced predictive modeling in the future. Okay, so just looking at a brief history of milestones that led to the advancements in fetal echo. In the 1970s, we saw the first M-mode imaging of fetal heart and 2D imaging. Of course, all that starts as research and then gets implemented into clinical practice. Okay, so in the 1970s, the first imaging of a fetal heart was attempted with M-mode and 2D imaging. It took 20 years. After that, to add color Doppler, post-wave Doppler, and then after that, we started moving every 10 years. So in the 2000s, we introduced 3D and 4D echocardiography, and then 10 years later, now between 2010s and 2020s, which is the current era, we have introduced AI, automated cardiac screening, tele-echocardiography, and extended access, especially in resource-poor settings. And this is an important point in tackling the disparities in healthcare. Okay? Alright, so we cannot talk about fetal echocardiography without looking at the unique fetal physiology on the one hand and the parameters that influence the embryology and the evolution and progression of congenital fetal cardiac problems. So, looking very quickly at the fetal physiology, we have two parallel circulations, we have three shunts, the ductus venosus, the PFO, and the PDA. And we have right heart dominance before birth. And understanding normal physiology is key to detecting pathology and looking at how these shunts play into the preservation of fetal well-being in the fetal life and then what we need in the post-fetal life. There are 2 points that are very important to remember when looking at fetal echocardiography. Number 1, we actually can see the progression of fetal cardiac disease throughout pregnancy. To see the final disposition or status of the newborn baby, we go through several stages. The first thing is, of course, the main formation of the cardiac chambers and outflow tracts. The second point is pulsatile forward flow. So we need those 2 things, okay, to influence or affect or predict the final outcome in the fetus. We actually see this changing in real time as we follow fetuses in prenatal life. So 2 things, the initial formation of the structures, and the second thing is pulsatile forward flow. Pulsatile forward flow is very important. For example, I could have a child, a fetus with critical aortic stenosis at 20 weeks gestation, only to become hypoplastic left heart at birth because of the lack of pulsatile forward flow in the chambers. So what I see at 20 weeks does not necessarily predict what I'm going to see at birth. So I have to follow this pathology and this fetus. Okay. So in the past 20 years, we have reached, number 1, consensus about the technique of fetal echocardiography. This was translated into guidelines. We have both the American Society of Echo and the International Society of Obstetrics and Gynecology unifying their approach to fetal echocardiography with statements issued every 10 years almost, starting 2004 and then 2014 and then most recently 2023-2024 guidelines. Okay? These guidelines are pretty much harmonized and they echo each other, basically. So we start always with commenting on fetal situs, and then the 4-chamber view, and then the left ventricular outflow tract, the right ventricular outflow tract, and the 3-vessel view, which is the screening view for a lot of lesions, but most importantly, coarctation of the aorta, because as you know, the sagittal and parasagittal planes can be very tricky when looking at coarctation of the aorta in the fetus because of the presence of the PDA. So the best way to screen for that would be from superiorly looking from above and looking at the 3-vessel view, which includes the pulmonary artery getting into the PDA and then the aortic arch and the SVC, and we can see the diameters of the arch compared to the PDA arch, and we can see the flow. And always if we see a retrograde flow in the ductus, then we predict that we're going to have a ductal-dependent lesion in this fetus when the fetus is born. Okay, so we're going to talk about them very briefly. These are standardized screening views. Okay, so the first thing is identification of the situs, looking at the stomach on the left, the descending aorta on the left, the IVC on the right, and this blue structure here is the entry of the umbilical vein to become the ductus venosus. Okay. So we're going from posterior to anterior in the fetus, and then we go and see the four-chamber view. We compare the atria, the ventricles, the sizes, the width, the length, the function, the insertion of the AV valves, the flap of the PFO. But there is one thing that is really important not to be missed here, and it is the axis of the heart. Only the axis of the heart per se can also predict pathology, even when we don't see anything else sometimes. So the axis of the heart is measured by taking a line from the spine to the trach, to the anterior chest wall, and then looking at the interventricular septum. The angle between the interventricular septum and that line constitutes our apex and the axis of the heart. The normal angle is between 45 and 65 degrees, and anything above or below should prompt us to look for pathology. Okay, so this is the left ventricular outflow tract, going anterior in the fetus, looking at the left ventricular outflow and aortic valve, and then more anterior, looking at the pulmonary artery and the branches. And then we have the three vessel view. This is the pulmonary artery PDA, this is the aortic arch in the middle, and then the SBC. And then we have two things, the diameter of the PDA and the arch, and the direction of flow. Okay. So, if we have any abnormality in any of the previous views, the baby is referred to the pediatric cardiologist, and we repeat these views looking at specific structures, but also we do sagittal and parasagittal and extra views. Nowadays, we are trying to do earlier diagnosis. So fetal cardiac imaging in early gestation, around 12 weeks, while we do the nuchal scan. It is recommended that we look at the following when looking at the heart. Number one, the axis. Number two, the four chambers and the situs. And then it's usually hard to look at the LVOT and the RVOT in this gestational age, so the recommendation is to look at the three vessel view. So the axis, the situs, the four chambers, and the three vessel view. All right. So since we're talking about revolution, so tools of this fetal echo detection revolution. So we started with 2D echo, going into Doppler, going to 3D, 4D. And then we have fetal cardiac MRI to look at more complex anatomy. And then AI with automation and early screening and the use of AI and machine learning. And I've looked at the program today. There are a lot of sessions about the application of AI in echocardiography. And then moving forward to tele-echocardiography, which is a way of sharing images and AI applications through clouds and connecting doctors globally. So this would expand global access and tackle disparities in healthcare. It has the potential to do that. Okay,
Commonly detected lesions are, of course, these are kind of easy lesions to detect: hypoplastic left heart, transpositions, AVSDs. Coarctation and tetralogies are not always easy to detect. So coarctation tetralogies need a little bit more expertise. Sensitivity ranges globally between 70 to 90% in expert centers. At the University of Jordan, we have a 95% sensitivity. And the important milestone to remember is the unification of standardized protocols by all echo societies, whether in the US or in Europe or globally. Okay, so the clinical revolution from diagnosis to management. We benefit from early referral to tertiary centers, coordination of cardiac teams, communication between the pediatric cardiologists, the pediatricians, and the neonatal specialists, especially in a place like Jordan where the care is centralized. So a lady pregnant with a complex congenital heart in the south or somewhere along the central areas might not have access to tertiary intervention early on. So fetal diagnosis becomes very important to refer the mother to the central areas, either in the north or in Amman, and have the mother deliver there to achieve the best care for the baby, in addition to counseling and mental health support for the family. Okay? This also led us to the possibility of fetal interventions, which are currently still in the research phase, but we have come quite a long way. So we have fetal interventions for aortic valvuloplasty, for critical AS, atrial septostomy for restrictive atrial septi, in hypoplastic left hearts, and recently, more recently, pulmonary atresia intact septum, pulmonary valvuloplasty. And this is usually performed through a collaboration between the non-interventional peds cardiologist and either the interventional cardiologist or an interventional fetal specialist, okay? We should not forget the ethical and emotional dimensions of prenatal diagnosis, family-centered communication, and shared decision-making. Okay, so we're going to talk very briefly about fetal interventions. Okay. The most common indications include the fetal aortic stenosis, which we said, because of the lack of pulsatile forward flow, can be the precursor of hypoplastic left heart. So if we can intervene early on, we could influence the progress of the hypoplastic left heart. Full-blown hypoplastic left heart with an intact or restrictive atrial septum. We do interventional procedure to the septum to decrease the gradient. Pulmonary atresia intact septum with concerns, when we have concerns for worsening RV hypoplasia. Okay, so those are the most common interventions currently still under the umbrella of research: aortic valvuloplasty, atrial septoplasty, and fetal pulmonary valvulotomy. Okay, and then once we start recommending this into practice, then we will have to tackle and be ready for the ethical and technical challenges that will come up. So just a very quick look at a fetal intervention. This is from Texas Children's Hospital with Baylor College of Medicine, looking at critical AS. Okay, so I'm going to try and highlight. Okay, here we have a very small aortic valve, okay, thick, and we have post-stenotic dilatation. It looks clearly a small stenotic valve, okay? And here we look at the left ventricle, and we have fibroelastosis. It's very evident, okay? And then here we have the high velocity of about 200 centimeters per second, confirming critical aortic stenosis. And this is, okay, here, a reversal of, this is MR with most of the flow going backwards. The regurgitant section is very high compared to the forward flow. Okay, so these are the parameters that we look at, and this is the fetal intervention. Okay, if we look here, oops, all right, right here, we're going through the abdominal wall, the uterine wall, and then we reach the left ventricle here, okay, with our catheter, and then we direct it towards the aortic valve, and then this is it, okay, being introduced into the aortic valve, this view and this view. Okay, so the issue of global access and the AI revolution.
Layla, 1 minute.
1 minute? Okay, so I just want to say that AI-assisted screening for low-resource regions emerged as a possible application of AI, telemedicine, cloud-based image sharing, and cloud consultation, in addition to doing training programs using the cloud. And AI bridges global gaps in care, which democratizes fetal cardiac diagnostics. The future. So this is, where are we heading? We're heading towards predictive modeling. So basically, a model of integrating fetal imaging with genomics and AI. This is where the future is heading: predictive modeling, integration of fetal genome and phenomics, cloud-based and AI-enhanced image interpretation, and this has, again, implications in global health and tackling down disparities, building bridges, and again, we should be ready for the ethical issues that will emerge in the future because of this, okay? So basically, technology, data, and compassion will shape the next era. Technology, data, and compassion will shape the next era. We should not, as we go into technology, forget the human side of this, the emotional impact on families, the importance of communication, empathy, and counseling, and leading the family to reach a form of closure when dealing with a tough topic and tough possible future, okay? And this should not prevent us from continuing to do direct interdisciplinary collaboration, okay? So from anatomy to anticipation, fetal echocardiography embodies progress in medicine, hope, science, foresight, and compassion. And every heartbeat seen before birth is a story rewritten before it begins. Thank you.
Thank you, Dr. Layla, for nice presentation and comprehensive talk. Question on the end of the session.
At the end? Yeah. Okay. Thank you, everyone.
صباح الخير جميعا. يعطيكم العافية على الحضور بهذا الوقت يوم الجمعة. المفروض الواحد يكون في بيته بيفطر مع عائلته. فيعني it's great خلينا نحكي gesture from all the attendee. طيب, we'll try to squeeze what we can during the next 20 minutes. So we're talking about life-threatening arrhythmia in pediatric age group. Now, we have a few things that we need to keep in mind, that if we don't diagnose usually the patient with life-threatening arrhythmia, and mainly we are going to talk about congenital form, it's going to be the problem with the adult, and usually you're going to miss an adult at some point of time. So we try our best actually to screen for this kind of arrhythmia and talk about them. So we have the first case, 4-year-old male presented with fever 1 day prior to admission. He was treated as a case of upper respiratory tract infection by his general practitioner. Next day, he had episode of pre-syncope. The mother described change of level of consciousness, but not truly he lost his consciousness. So then he presented to the ER. Apart from the history, the only major thing that was significant that he had family history of 2 sisters died at 7 months and 5 months of age with febrile illness. And again, his maternal uncles died at the age of 17, and the other one died at 24 years of age. Now, he had an ECG at that time in ER and showed the following ECG for him. And if we are going to tackle our brain, do you see anything significant in this one? So forgot about the rhythm. Right now, we have what we call accelerated ventricular rhythm, we have junctional ectopic rhythm. Started as sinus, then we have ectopic, and it's not that much important. But the mainly striking thing actually is that he got, if you look again, look where his QTC end, it's extremely prolonged. So the QTC is right now is ending here, or for example here. So he had actually very prolonged QT in this ECG. Now, this is a typical presentation for prolonged QT syndrome. And again, as we mentioned earlier, just quickly, I can see a good number of students here. Usually, if the QT end beyond the half, the distance between the RR interval, usually you're going to consider it as prolonged. Now, there's something else. So, for example, but that not always applies, because in tachycardic patient, when high heart rate, it's going to end beyond that half. Now, this is again, so this is another child who was a newborn, and he was admitted to the NICU for dusky color, and they attached the monitor, and it showed this rhythm. So again, any ideas quickly? Exactly. So this is a torsade de pointes. So long QT syndrome is characterized by prolongation of QT and interval, and also T-wave abnormalities. So long QT syndrome, actually, it has 2 categories. We are mainly talking about the main one here. So we have congenital and acquired, and as you know, there's a lot of electrolyte imbalance that can cause this. Apart from that, the main aim here is talking about congenital one. So it's mainly caused by genetic mutation in gene coding for cardiac ion channels or the regulatory proteins, resulting in altered channel function and prolonged repolarization. So as a summary, it's a disease of repolarization of the heart. And again, as we are really caring about depolarization, repolarization is extremely important. So we have at least 17 mutations, but in classical teaching, and the most important one, they are the first 3. So we have prolonged type 1 QT syndrome, and we have KCNQ1 gene. We have type 2, we have type 3, which involves sodium channels at that time. The first 2, they were related to potassium channels. And the third gene, actually, it's also associated with the Brugada syndrome, if you remember that. So it's accounting about around 90% of all cases of prolonged QT syndrome. Now, the prevalence of congenital lung QT syndrome estimated about 1 in 2,000 to 2,500, which is really not uncommon, we can say. So it's in population in Jordan, you are going to find good number with these cases, actually. So now, why we need to know about it? Now, again, it's mainly we are talking about arrhythmia, what we are going to take care of, actually, to spread the knowledge of this. So sudden cardiac death, I think we had lecture yesterday about that, if I'm not mistaken. It's really rare, but it's a devastating event, and estimated about 0.7 to 10 per 100,000. And where we stand in Jordan, unfortunately, we don't have actually studies to explain about this burden. And again, sudden cardiac death in pediatric, actually, like if you are going to ask our pediatrician colleagues are going to have explanation, like, for example, sepsis, you're going to have neurological, structural, cardiomyopathy, anything else, aspiration. But it's going to be underestimated to think about arrhythmia. Now, even internal medicine, our colleagues also internal medicine, apart from our cardiologist, so they are going to think about ischemic heart disease mainly, even if he was at 20 years. The first thing it's going to be mentioned that he died because of cardiac MI. Now, we usually start teaching our resident, what do you call two pediatrician reading an ECG? It's really double-blinded study. And it's because ECG is challenging for even the cardiologist. Now, we start with the basic things, how we're going to measure the QTC. Again, there's a lot of papers just trying to describe how we're going to measure the QTC interval. And again, we are going to start from the Q wave to the tangent line that cross the isoelectric line, and then we are going to measure at that time the QT and correct it to the previous RR interval. Now, there's a few challenges actually which lead you are going to use. For me, use the best lead that you can find the QT with like a clear border. But there's a good talk about, for example, the cardiac axis leads, for example, lead 2, V6, which they are really considered a good one. But sometimes you can even, if you find, for example, lead 3 was the best one with a clear distinction border for the QTC, you can measure it. Now, again, there's a few things to consider, for example, if it is biphasic, if it's negative, where you are going to measure it. Usually, we don't involve the U wave again. But for example, if you can't separate the U wave from the T wave, you are going to also include it in the measurements. The other things that, for example, when we have a prolonged QR complex, in case, for example, right bundle branch block or left bundle branch block, we have something else, we call it GT interval, which is different and it has its own values. Now, quickly, we are talking about this, which is Schwartz and the correct way of diagnosing, we get a scoring system for that. For example, we started with the measurement of the QTC, and each one it has points, for example, more than 480, it's 3.5, to, for example, in 450 millisecond to 460 in males, it's 1. And again, it turns out the point has got 2 points, T-wave alternus, not T-wave lead 3. So there's a scoring system for that, for example, even involving the clinical history, the family history, and the genetic finding, which is extremely important. And again, if you got, for example, more than 3 points, then you have a clinical diagnosis of along the QT syndrome. Now, cardiac features, again, we start with the T-wave abnormalities, including T-wave alternus, not T-wave. So it's repolarization anomalies, and it's going to be evident in the T-wave itself. Or, for example, if we have ventricular arrhythmia, we are talking about the polymorphic one, which is torsade pointers. Now, usually it's self-limiting and self-terminating, which is very, very luckily. And because of that, you will find the most common, like, for example, presenting thing or like symptoms really wise, it's syncope or dizziness, palpitation. Now, syncope, as we mentioned, it's the most common symptom and happens without even a warning, usually. So it's not mandatory that the patient was going to feel palpitation before he has the syncope, which is related to torsade. Now, cardiac events like syncope, cardiac arrest, or sudden cardiac death may occur in infancy through the middle age, and most commonly from the preteen years through the 20s. Now, we are not going to talk about the details how this disease is going to be acting during the adulthood. But again, now we look at this few numbers right now, for example, related to depending on genetic mutation we have and the type. As you can see that they average that in QT1 or 2, usually it's going to be around 480, which is not that much significant from type 3. Again, there's some morphology that give you a clue which kind of prolonged QT syndrome type you have, but the best or the gold standard is genetic testing. But at least it can help you to decide if you are going to start your management, which is going to be, we have cornerstone management of that, and again, mainly for type 3, we have a different medication we are going to mention later on. Now, as you can see, usually the all cardiac events in type 1 is the most common to have. Regarding the aborted cardiac arrest, it was mainly in prolonged type 3, and sudden cardiac death, usually it's most commonly to happen at type 3. Now, again, this is a quickly, which is really dangerous if you see this kind of ECG. So this patient has a T-wave alternance, as you can see. It's really that means this patient is most likely to have torsade very early. Now, it's not exclusively that T-wave alternates, especially like it's going to be found mainly in prolonged QT. There's a few things that can happen, which is also related to repolarization anomaly. But once you see this one, and like with the prolonged QT, as you can see where the T-wave ends, this is really one of the very high risk factors. Again, now this is quickly for our colleagues. So this is, for example, a neonate who was born at 40 weeks, and he found to be bradycardic. So initially they thought it was heart block, complete heart block. And then after a careful look, they said it's 2-to-1 block. But again, this is a typical presentation for prolonged QT syndrome type 3. So there is a functional block, as you can see, with conduction 2-to-1. So there is the first P wave. It's a little bit slow. Okay. Again, I think it's clear, as you can see, that there's 2 P wave before each QRS complex, and that the one in the middle is the T wave. So this is where the T wave actually. So it's between the 2 P waves, as you can see. So the first thing is the first P wave. The second one is the T wave where it ends, and then the third one, which is the conducted P wave. Again, this is also very risky patient, as he's going to have a torsade. And actually, the first video of the torsade, it happened for a patient who had similar ECG. Now, quickly, this is the torsade de Pointes, and as you can see at the beginning of that ECG, the trigger, so there was a BVC. So there was a BVC which happened on that T wave. So there's a T wave, and actually it was prolonged. And then what we have a BVC, which was what you call R on T, and that triggers the whole torsade de Pointes. Now, as you can see, it's not really, like, for example, can't be sustained. It can terminate, rehappen again. So not every torsade that will lead to cardiac arrest and result like to end up in the VFib. So the one who dies usually who ends up in VFib. But there's a good chance that he have torsade and then return back to his sinus rhythm. Now, again, this is another one of torsade. Again, you have to have a good eye look for the torsade. And you can, like, for example, this one is a little bit tricky for untrained eye. But this is also another example of the torsade, which is really what you are going to look for is the twisting against the isoelectric line. Now, for our cardiologist colleague, we have some challenges mainly related that even you have a prolonged QT syndrome with positive genetic testing, and they still have normal ECG at baseline. But for example, they have really strong family history of prolonged QT syndrome. They have, for example, recurrent syncope. So this is a great paper actually from Melbourne. They did a good study, and they included a good number of patients, around, I think, 100 patients. Healthy individuals, and they did exercise tests. Usually one way to diagnose prolonged QT syndrome is to check the dynamics of QT's interval during the exercise. So for example, it's not going to get shortened with exercise as we are expecting, and usually you are going to measure it in the recovery, and in the recovery it's going to get prolonged again up to the normal, but in prolonged QT syndrome it's going to be more evident. So this is a good number. Actually, that was a study that I use the numbers to diagnose some patient with prolonged QT syndrome, or at least to give me a clue about how they behave during the exercise. Now, management, we are talking about mainly the main cornerstone is beta blocker, and the most important beta blocker, unfortunately, we don't have it here in Jordan, which is the nadolol. We have some access to the neighboring countries. I have a few patients. For example, the first case we mentioned, I started that child on nadolol, and the family brought nadolol, and they started actually, his mother unfortunately passed away also with prolonged QT syndrome, and he got also another 2 siblings with prolonged QT syndrome. So I started him on nadolol, and hopefully we are going to convince the family to insert an ICD very soon. Now, propranolol, so mainly we are talking about non-selective beta blockers. I had one mentor who his name was Andreas Flammer from Germany. Actually, he used atenolol, and there's a good study to compare between both like nadolol and atenolol and propranolol. The superiority is mainly was for nadolol. Now, again, it has the effect of blocking the pro-arrhythmic effect of stress and physical activity and preventing early after depolarization through blockage of increased calcium current led by the adrenergic stimuli or late inward sodium current in case of propranolol. Now, regarding the torsade, again, it's a ventricular tachycardia, and we are going to follow the guidelines of BLS or, for example, ACLS. If your patient is stable, that's perfect. If he is going, for example, unstable, but he has got pulses, you are going to do cardioversion. If he is, for example, arrested, or for example, there is no pulse and you found torsade, then it's going to be defibrillation. It's going to be unsynchronized. Now, or the classical thing is straightforward. If he's good, like looking well patient, hemodynamically okay, you start with magnesium sulfate, which is the most important thing. You can use lidocaine, lignocaine, whatever you have. Now, we are not going to talk about the other details of the other types. So, for example, some of them we can supply them with potassium supplement, carbonic anhydrase inhibitors also. But again, remember that beta blocker is the cornerstone. Now, regarding this is from the European Society of Cardiology 2022 guidelines. Again, as you can see, the beta blocker is the cornerstone. I showed this one mainly because if we have type 3, we are going to use something else. We call it mixilitine. And again, unfortunately, we don't have it in Jordan, but usually we have access to the neighboring countries to get it. As you can see, depending on the management, we can upgrade, for example, for ICD, or for example, we do the left side, left cardiac sympathectomy, one of the great measurements actually we can use. Now, next case, it's going to be 7-year-old boy admitted to the PICU after witnessed cardiac arrest in a public playground. Fortunately, doctor was there and he started his CPR. We don't have that, but actually this case was in my fellowship area in Melbourne, so it was not doctor, it was a bystander, because they have a great literature, they have a great sense of responsibility about this kind of stuff, so you have a good number who can do basic life support. So they started CPR, then the ambulance arrived and they took over him, and then he had regained his circulation like after 5 minutes of CPR. So then he was admitted and he was in sinus rhythm at that time. He had a quick echo that showed normal cardiac function, low normal and normal cardiac structure, but he had some hypotension and her perfusion was not great, so they started him on adrenaline. So when he started the adrenaline, then they got this on the monitor, and as you can see that there is bigeminy, ventricular bigeminy. So it was initially started as a few BVCs, then it started in frequency, then you had a few couplets. So again, this is any ideas from presidents if we have. So let's go to. So this is CBVT. This is bidirectional CBVT. This is bidirectional ventricular tachycardia. So again, if they continue to have the adrenal infusion after you see that BVCs and it's going to increase the frequency, you should have some checkpoint that there's something wrong happening there. So he got some history of sudden cardiac arrest, or what we call syncope. Then he got BVCs, which is increased by the adrenaline. This should raise what we call, this is bidirectional ventricular tachycardia. Once you have bidirectional ventricular tachycardia, there's a few things that can cause that. One of them is the CBVT. The other thing, which is the digoxin toxicity, which is going to be encountered in adults. And the third thing, which is Anderson-Towel syndrome, which is part from the prolonged QT syndrome. Fortunately, we don't see that much, but what we are going to take care of is mainly CBVT. So it's inherited arrhythmia syndrome that's characterized by exercise or emotional stress induced bidirectional polymorphic ventricular tachycardia in patients with normal ECG at rest, except very minor detail. We are going to talk about it later. In the absence of structural heart disease, prevalence is unknown because there is like not that much great number of studies, and again, unfortunately, most of the patients they die suddenly. They are not even included in the study, so there is some like bias even in the number. But for example, it's approximately 1 in 10,000. So if we are going to talk about Jordan, we are going to have around 1,000 plus, like 1,100 cases, if it was really truly that the what we're going to present our country. Now the mutation, they have 2 mutations mainly. RYR, 1 minute, yep. So it's mainly the autosomal dominant form. We have the other autosomal recessive, which is calsequestrin type 2, which is related to the autosomal recessive. Now, while majority of cases are triggered by emotional stress, exercise, a few of them actually they were found to happen even at rest or some atypical like a trigger. Some patients, they even were treated as epilepsy and they have anti-epileptic medication, but unfortunately, they still have this form of epilepsy because they had even CBVT that can have some abnormal movement and fecal incontinence. Now, failed anti-epileptic medication, you should always raise suspicion that there could be underlying cardiac cause for that syncope. Now, not all leads will show bidirectional VT, so I always tell our resident, never judge on one single lead. Again, most common supraventricular manifestation is sinus bradycardia, so if you have patient who has recurrent syncope and his resting heart rate is bradycardic, it should raise some suspicions about that. Again, usually we do exercise tests to do it, but not the usual exercise test. We do what we call sprint tests. So we don't do protocol, for example, that we do for prolonged QT syndrome. We do sprints, so we increase the speed very, very quickly. So we need to do some rush of adrenaline, but again, it should be done in controlled environment. That means it should be done in hospital. Don't do it in a clinic if you have really high suspicion of that. Now, this is another, just to tell you that not all leads is going to show it. So it's mainly, as you can see, it's mainly evident here in lead 5, the last one from bottom. Now, treatment, again, it's during resuscitation from like a storm of VT, usually your thing is that you should recognize it, stop the adrenaline if you was on adrenaline. You need to administer general anesthesia, opioid, and the most important thing actually is IV beta blocker. We don't have IV propranolol, but we have, for example, IV ismilol, which is started, I think, around 1 year in Jordan. IV flecainide is another great option if this patient is really hemodynamically unwell. Again, long term, you need nadolol, flecainide, and again, here you start with cardiac sympathectomy. Again, last resort is ICD, because ICD itself, it can trigger adrenaline rush and it can worsen things. Last thing to mention that you should have a good counsel for the family. If you have prolonged QT syndrome or CPVT, it's like your measures is like one who's in the car driving with 100, so he is at risk of having accident. So you start by slowing the speed, you remit the exercise for that child. Then, for example, then you add an extra layer of protection, which is the seat belt. Then you add, for example, the airbag, which is, for example, the sympathectomy, the seat belt. So it's multi-level, multi-layers for that safety. Now, honorable mention just for our students here or representatives, never forget that the sinus tachycardia. For me, I'm worried about sinus tachycardia in a patient more than actually ventricular tachycardia, because we have a lot of reasons to cause this form of sinus tachycardia, from malignancy, sepsis, septicemia, septic shock, whatever. And the last thing, I think Dr. Khalid is going to mention that JET, which is junctional ectopic tachycardia, because it's going to was one of the major cause for mortality in post-operative area. Thank you very much for your attendance. And again, conclusion. So we need to mention that knowledge is power, spread this thing. And where we stand in Jordan, we should actually spread for example, the use of AAD, to encourage to have it in public areas. And we need to get our national guidelines, and we are playing in the same team. Thank you very much.
Alessandra? Now with Dr. Alessandra Frigiola. Next speaker will be Dottoressa Alessandra Frigiola.
ايه خلاص
Yes, and the way she was confused on the sun, so she's in London. She's not here.
Yeah, so she should continue her and those two.
She's not here.
يرجع
Now we return to Prof. Gabriel Nianti.
Yes, but I don't succeed in the going forward. But it's not possible to go on with my presentation because the slide on the okay.
Yes, we see your screen. Go ahead, please, Doctor.
As you can see, evaluation plays a central role in evaluation of many activities. And
Return from the beginning, please.
excuse me?
Go ahead, start, please.
Okay, can go on. And so, from the result of evaluation, it's possible to plan the management of any patient with heart disease. Go on, please. But why echo is so central in diagnostic workup? Give precise information about anatomy and physiopathology, is safe for the patient, is easily available, may be repeated anytime, and the last but not the least is cheaper than any other technique that used in cardiology. The next one. The diagnostic power of the echo is increased during the time, and the improvement is related to the greater passes in the engineering in the use of ultrasound. And now we have, for example, probe to our disposal that allows for 3D reconstruction of the heart. TA probes becomes more and more efficient. And finally, the echo machine are now equipped with integrated intelligence system that enable automated standardization and reproducible analysis of cardiac ultrasound data and for our echocardiographic data. The next one. As you can see, at the beginning of the 70 years of the last century, the only possible modality to evaluate the heart with echo is a multidimensional mode. Nowadays, we have a complete 3D reconstruction of the heart that able to us to identify correctly the cardiac structure and to elaborate the ventricular wall to have a complete evaluation of the volume and function of the ventricle. But also with the there are very good Doppler modification from with a coil flow that allow us to evaluate the flow into the heart. But not only when this Doppler was applied to the motion of the wall of the heart, it's possible to identify function of the heart. Next one. But what is the impact of these technologies on the study of congenital heart disease? First of all, the quality and resolution of the imaging has increased. We allow the possibility to use 3D echo and transesophageal echo even in infants, and this this train offers the opportunity to study a new way the ventricular and atrial function of malformed heart before and after surgery. And this in the future could impact on management of this patient. The next one. But these technologies are not available every way to the cost. But we know that population with congenital heart disease, a very heterogeneous population. We all the epoch of the life are represented, from fetus to old adult patient. Secondly, there is a high number of heart malformation, sometimes mixed in unusual mode. Some surgical technique radically modify the anatomy and hydrodynamic of the malformation, and there are very different complications, basically related to surgical or interventional procedure. And this has two consequences. The first consequence is that to correctly perform echocardiography is necessary that there are not working, but I don't know why. There are expert operators, and secondly, a different approach and different exam conduction are required. In fact, only a few words about the fetal echocardiography. I want to remember that in the incidental world, the incidence of some complex malformation changed radically, because the early detectment of a malformation allowed to the parents to decide if interrupt or not the pregnancy. And many times there are parents that in present of very complex malformation, for example, hypoplastic left heart syndrome, decided to interrupt the pregnancy. And so this malformation, for example, in Italy, is completely disappeared. But when we approach the patient with congenital heart disease, we know that there is a very different modality to approach this patient, but because also the echogenicity is completely different. For example, in an infant and children is very good, and in this situation is a transthoracic echo give up the opportunity to have a perfect definition of the malformation. On the contrary, in some adult patient, because of the presence of multiple scar or thorax deformities, it's necessary to recur to transesophageal echo. But not only frequent evaluation of congenital malformation is frequently necessary through the use of axis view because of the presence of malposition of the heart, ventricle, and vein arteries. And there is another aspect that in evaluation of congenital malformation, usually some projection are some views are therefore inverted to have a better correspondence with anatomical aspect. We know that the congenital malformations are numerous and in some situations very complex, and so for a good evaluation of this malformation is necessary to a sequential approach. The sequential approach is related to the evaluation of the atria, ventricle, arteries, and the veins are connected one to another. Not only the type of connection is the connection scope and so on, but also with the mode of connection, if it's one valve, two valve, or if the valve is atretic or perforated. And then after, as you can see here, we have some type of anomalies or atrioventricular connection in this figure. This view, we have corrected transposition of deep arteries, where the left artery is connected to the right ventricle. Or in another situation, we have normal concordance between the atria and the ventricle, is a univentricular is a single ventricular valve. Or in the other situation, we have a tricuspid the connection of concordant, but there with a tricuspid lesion. Or again, in this situation, we have a classical discordant ventricular area discordant as the transposition of the arteries, or in this other situation where there is a single artery from the post ventricle, that is a truncus arteriosus, where there is an aorta, and from this truncus there is also the pulmonary artery. Or in the other situation where there is pulmonary atresia, where there is a complete obstruction to the right ventricular outflow. When we evaluate the atrioventricular connection, we have to evaluate pulmonary venous return. Usually, the anomalies of venous orders. Yes. The connection of systemic vein are sometimes are normal, but this abnormality not touch the physiology. So, for example, we have a superior vena cava that left resistance or left superior vena cava that drain in the coronary sinus. That is anomaly, but from a physiological point of view, there is no abnormality. And the more less common are the pulmonary venous return that may be abnormal, and usually are the cause of all right ventricular overload. When we have evaluated the connection, there is evaluating if there are other malformations in the heart, because sometimes has normal, perfectly normal connection, but we have other certain effect, as for example, here a certain effect, or obstruction to the outflow, in this case aortic stenosis or pulmonary valve stenosis, or anomalies of atrioventricular valve, as in this situation where there is a venous plastic mitral valve, or in the other situation where we have more lesion than present together, as in from the Technology, where there is a ventricular septal effect associated with the obstruction to the right ventricular outflow. But in the evaluation of anatomy, trachea extraction and TA are very important. In the presence of poor consanguinity, especially in the patient, it's important to perform transesophageal echo. You can see as a large intermittent septal effect defined in the transesophageal echo. But the strict prenatal echo is very useful to define the anatomy of a particular or cerebellar valve or atrioventricular valve or ventricular septal defect. As you can see in this slide, here we can see a tricuspidal truncal valve, or this is an extraction of the tricuspid valve in left side anomaly. And here we can see the extraction of the ventricular common atrioventricular valve in the canal. But especially because we have to do with the patient with different body surface area, it's very important to define if the dimensions are normal or abnormal, and for this purpose it's very important to use the data score. And fortunately, we have responsible in the internet application that allow us to immediately calculate the zeta score and the single structure, and so we can understand if the structure is small or large. But there are evaluation, especially for evaluation of operability of some malformation, it's very important to have index that tell us, for example, if the pulmonary artery are normal or abnormal, for example, like a index, or we have another evaluation, for example, to evaluate the annulus of the acoustic valve to decide if there is possible the presence of pulmonary valve atresia, the type of aneurysm. Another important aspect that we can use with echo is evaluation of the flow, is called flow, and the flow can be normal as a start, or here as a figure, as a skew, or maybe abnormal in this situation there is a large ductus arteriosus, or in this other situation we can see the interventricular septal effect, and we go with the flow, we can decide not only the intensity of the flow, but also the direction of the flow. Next one. And so we can, where echo is possible to evaluate the gradient, we can evaluate the pressure in the ventricle, and go on. And the previous one is that it is also possible to have a correct, a more precise evaluation of the flow across the single structure, and so we usually either two-dimensional echo, basal Doppler echo, is possible to calculate the flow across the single structure, and so we can have an idea, precise idea of QPQS, or define the constitution fraction in presence of mitral or ticus, or mitral or aortic complex. The next one. Next one.
You can enter the lecture in 1 minute. Okay?
Yes. I can go on.
To finish the presentation in 1 minute.
Yes, I can. Okay. We can go on. These, for example, how the anatomy is completely modified by surgery, this is a frontal operation, or in this situation, we have a contour that connect the right ventricle to the pulmonary artery. Next one. Next one. We can evaluate with echo the function of the ventricle. Next one. Or calculate the deformation of the wall of the ventricle, and this is very important new possibility that because we know that the modification of strain correlate with the function of the ventricle, and usually a modification in strain precedes the decreasing of ejection fraction. The next one. Next one. We can use echo for example, we can use oil stress echo to evaluate some situation borderline and decide what to do. The next one. Or the echo is very important. The previous one, please, and I haven't finished. The previous one. Okay, and with the echo it's possible to monitor interventional procedures. Some interventional procedures are performed exclusively with echo monitoring, for example, Ashton procedure or PDA closure in a preterm infant, or septal defect closure or valve implantation. Or again, echo is very important in monitoring the operating room for evaluating exit from the bypass or the result of surgical procedure. The next one. Echo is very important evaluation of the result in intensive care unit. Next one. So echo is a powerful diagnostic technique, but its result must be interpreted keeping the clinical context in mind. Clinical picture and echo result should be always comparable. If this is not the case, a critical evaluation should be done. The next one. Next one. Echo is a powerful diagnostic technique. Hello, a precise description of anatomy and pathophysiology is useful in cath lab and operating view, but there are limits. Visualization of everything that is outside of the heart is not always possible, especially in adult patients. Visualization of coronary arteries is not possible completely. We can see only the origin of coronary artery. Definition of volume and function of right ventricle may be difficult in some situations, and echo doesn't visualize the pressure and resistances. So, if it is necessary to have the evaluation of this component of the heart, it's necessary to perform other techniques for evaluation to obtain a complete evaluation. Thank you for your attention and present this presentation.
Grazie mille Prof. Gabriele Vignati per questa completa e interessante presentazione. Thank you so much for this comprehensive presentation. Okay.
Thank you for you.
Next speaker. Okay.
Hello, hi, good morning, good morning. Thank you for inviting me. And I'm sorry, I think there was a big circle with the UK time and Jordan time at one time. Sorry about that. Can you hear me all right?
Okay. Firstly, welcome Dr. Alessandra Frigiola from Jordan-University from Amman. Alessandra Frigiola, doctor at Thomas Hospital from London. Okay. She is a consultant cardiologist and consultant in adult congenital heart disease. Okay.
Okay, thank you for the introduction and thank you for inviting me here. So, and yeah, as I said, apologies if I didn't connect at the right time. I just got a misunderstanding of the time. In the next 20 minutes or so, what we will be focusing our attention on will be another aspect of the multimodality approach to patients with congenital heart diseases, which are cardiac MRI and cardiac CT. With regard to imaging, and generally speaking in congenital heart disease, we have to be clear that imaging guides medical structure and surgical therapy. But it's very important, actually, it's crucial to know and to be familiar with the cardiac anatomy, with the pathophysiology, and what are the surgical and percutaneous interventions that either have been performed or the patient needs to undergo too. And it's very important that we know the clinical question, so we answer with our imaging and modalities the clinical question and what the physician needs to know. We need to understand the advantages and the limitation of each imaging modality, what's the resource availability and feasibility, what's the expertise in the center where we work, and remembering always that the approach to these patients is a multimodality, with echocardiography being the first cross-line, cross-sectional imaging modality. When we talk about patients with congenital heart disease, we're fully aware that we look after them since the fetal age, since their fetuses until adulthood. And generally patients are palliated, but they are not cured by the intervention that we propose or we do to them. And therefore residual lesions remain, and imaging is a key modality to follow them up. When it comes to MRI and CT, there are advantages and limitations to both. MRI is a non-ionizing radiation technique, which is very helpful for ventricular function, shunt quantification to assess regurgitant fraction, tissue characterization. There can be contraindications such as specific metallic implants or when patients suffer from claustrophobia and they're not suitable for this type of imaging. CT can be very helpful when we look for small vessels, airways, stents, for instance, or when there are contraindications to MRI, or when we need a better understanding of coronary arteries, for instance. This is a pie that basically shows the distribution of the various diagnostic techniques in our institution last year. Cardiac CT represents about 15% of the total diagnostic tool, but yet is important and is increasing. This is in the adult side. In the pediatric side, it's much bigger because it avoids the need of general anesthetic. MRI occupies most of it, transthoracic echocardiogram occupies most of the pie. Cardiac MRI becomes the second most commonly diagnosed imaging modality, and cardiac cath is the third. These are the indications for cardiac MRI in adult congenital heart diseases, such as assessing right ventricular outflow dysfunction, particularly to time reintervention and for procedure planning. Patients who had TGA, post-atrial or arterial switch, full time circulation, and mainly to assess function, anatomy, and collateral flow, partial anomalous pulmonary venous drainage, atrial septal defect, particularly when they are borderline, and we need to look for the pulmonary venous drainage if they were not seen on TOE. aortic valve disease, aortopathy, aortic arch abnormalities, pulmonary hypertension, and other complex congenital heart diseases. These are the indications for cardiac CT. Again, in our institution, you find the same panel of diseases, but particularly Marfan patients and patients with aortic valve disease. In fact, most of our protocols include the Ross-Pairs, which I'm going to talk later briefly, Pairs procedure, and partial anomalous pulmonary venous drainage, pre-stent, and finally coronary artery disease. Now, what I would like to do is purely to start with some clinical and just show some clinical examples of application and interrelation of both MRI and CT. So the tetralogy of Fallot is the most common cyanotic congenital lesion, so it's inevitable that we have tetralogy in our examples. It's characterized almost inevitably in all patients by residual right ventricular outflow dysfunction following initial repair. And by the age of 35, half of these patients required already a valve replacement, generally performed on a mean age of 21 years. And so assessing the flows, assessing the anatomy and the volumes becomes really important. With MRI, unlike echo, we can assess the flow in any plane. Even when the conduit are present and are very anterior and more difficult to see on echo, with MRI we can absolutely plan our flow how we want. We don't have an instantaneous peak flow, so what we have is an average flow over a multiple cardiac cycle, so the peak velocity might be lower than that we obtain on echo. But we can obtain information on regurgitant fraction, for instance, as I'm going to show. The planning, however, is very important. It's very important to be perpendicular to the flow direction. And then this is the example of a pulmonary valve. We have an example, we have an accurate understanding of what's the anterior flow, retrograde flow. We can calculate our regurgitant fraction. Volumes, the MRI is the gold standard for assessing volumes, particularly for the right ventricle, which, as we know, is behind the sternum. In adults might not be as easily accessible, and to assess changes over time. It requires an accurate segmentation of the end-diastolic and end-systolic phases to obtain the parameters we are interested on. And they're very accurate. Whether patients have a surgical or a percutaneous approach to the pulmonary valve replacement is very much dictated by pulmonary morphology, size, dynamics, which can be assessed with CT, but more often we use 3D SSFP MRI images because they do not involve any radiation. what we have, we obtain very accurate information on three planes, axial, vertical, and longitudinal, and therefore we can obtain measurements of the areas of interest for the interventional cardiologist to tell us whether a percutaneous pulmonary valve is feasible or not. And then we can also look at the position of the coronary arteries, which, if very close to the pulmonary valve, may contraindicate a percutaneous technique. We can also perform tissue characterization as a way to stratify the risk for arrhythmia occurrence in these patients. This is an example of 3D LGE, and we can see that with every centimeter cube of increase in RB LGE, there is an increased risk of inducible VT. When there are metallic implants, we need to know which sequence to use. If we use MRI to assess the patency of a stent, which is not very well seen on echo, we need to use sequences that are less affected by metal artifact, generally more T1 weighted, as MRI people would say. Black blood images are very helpful. We can see whether the stent is patent in its cavity. But CT can offer further evaluation. This is an axial view of a stent where we see it's broken in 3 points, and these are diastolic position as opposed to diastolic position on the right-hand side of the stent of the pictures. And we can clearly see the mechanism of obstruction. The patient presented with the increased velocity across the stent, and CT just elucidated the mechanism of failure of the stent valve. CT is also used when we want to plan for the new self-expandable devices. There are specific protocols that we don't need to go through and read the protocol that is on the right-hand side, left-hand side of the screen, just to show how we try to obtain dynamic information, and therefore we look for function. We can look for the pulmonary venous return, and that's particularly helpful when the patients have a borderline shunt and we want to decide whether it's worthy or not to proceed with closure. Also, we can assess modified lesions. Size in the ASD, I would say, is better done with TOE. However, we can have a good idea of the size of the ASD if we plan our flow accurately through the interatrial septum, and we know exactly where the defects sit and more or less what the size is, and there is a good correlation with TOE as well. So we might spare some patients a TOE, which can be done on the same setting of ASD device closure under GA. And the shunt is calculated as the relationship between the net arterial flow in the main pulmonary artery over the aorta. Patients with partial enormous pulmonary venous drainage pre-procedure are generally assessed using CT, but MRI can also be used. As we see here on the axial images, there was an anomalous drainage of the right upper and right middle pulmonary vein to the SVC and a superior sinus venosus defect. The images are acquired within a few seconds. There are various protocols. I've been testing a few to see what gives us the best image quality. I try to have enough blood flow both on the right and the left heart and not too much streaky artifacts in the SVC. The images, as you can see, that's a superior sinus venosus defect. We can see straddling of one of the pulmonary valve at the level of the interatrial septum. Can be used for, they were used initially to obtain a 3D printed model and to test in vitro the possibility to repair the PAPVT with a stent. Now we don't need this anymore because the interventional cardiologists are quite experienced, and based on the images they can decide which stent they prefer to use to correct the anomalously draining pulmonary veins. In patients with transposition of the great arteries, as you know, patients may undergo arterial switch procedure, which may cause issues at the level of the coronary arteries, at the level of the upper tract, at the level of the branch pulmonary arteries.
And of course, there can be perfusion defect, and therefore we look for function of the ventricle and regional wall motion abnormalities. In terms of pulmonary arteries, as you know, sometimes they're really difficult to see on transthoracic echocardiogram, whereas they are beautifully seen on cardiac MRI. This is a patient whose left pulmonary artery could not be seen on echo, and then when the patient was completely well and asymptomatic, he came for cardiac MRI, and then we could see a very string, a very hypoplastic left pulmonary artery, which accommodated 10% of the antegrade flow in the lungs, but the lung was perfused, and therefore the patient underwent stenting of the left PA. But that could not be seen on echo. With regard to coronary arteries, we know that lots of these patients have anomalous coronary artery. This is an 18 years old that developed chest pain on exertion, and the CT elucidated the mechanism of chest pain. Basically, the left vein was pulled between the two arteries with a very small slate-like costume, and there was actually also an intramural course, and the patient required surgery. So that's how CT really had to delineate the anatomy and the position of the coronary artery to plan surgery. In patients who underwent an atrial switch, again, volume function, particularly of the systemic right ventricle, are easily obtained with cardiac MRI. We can assess the degree of tricuspid valve regurgitation, but particularly we can look at the pulmonary and systemic venous pathway. If there is suspicious of a narrowing, the patient not necessarily need a cardiac cath. We can assess the pathway in cross-sectional plane, but also we can obtain information on the flow through the pathway. In this case, there is a slight flow acceleration that achieves 1 meter per second, but with return almost to baseline. Yes, there is some high flow acceleration, but the pathway is basically patent. And also we could identify shunt when there was a pathway, a path leak. In patients with aortic partition, MRI and CT are very helpful, as I'm going to show in a second. MRI is particularly helpful to assess and have an idea of what the anatomy looks like. We don't take measurements from MR angiographic images, but from 3D SSFP, as I'm going to show in a second, which are ECG gated and respiratory gated. We can have our information on the effect of the high blood pressure on the ventricle, so we look for function, mass, we can look for coronary artery disease potentially, and we can assess collateral flow. Diameters are generally taken either in diastole or systole. We tend to do more diastole, but there are some that are allowed dual acquisition. And then we can also assess the velocity. I would say sometimes the echo can struggle if the anatomy is very complex of the proximal descending aorta. But when we assess the flow, we can do that through in plane, as in the top right picture, or we can do in plane. In that case, we need to go really through the narrowest side, because the more distant we go, the less accurate the peak velocity that we obtain is. And of course, like on echo, we look whether there is a diastolic tail, which is indicative of significant narrowing. We can look for complications. Sometimes in adults particularly, the aneurysm can be missed because the suprasternal view are not necessarily so good to look at. We can have some idea of the mechanism of dilatation. In this case, a very narrow, very narrow, but rather hypoplastic, small caliber aortic arch with flow acceleration, which hits the posterior aspect of the aorta, causing dilatation. If there are stents, they might be seen quite nicely on MRI. Again, on angiography, they look like a void. Black blood are very helpful, but CT is also very helpful to understand the mechanism of narrowing, for instance, of a stent, like in this picture, where there is a clear rupture of the stent, and so we know why the gradient has gone up in this particular patient. Occasionally CT, but that's only in hospitals where there is a strong department of biomedical engineering. They use finite element analysis and computational modeling to assess what type of stent could be best placed in this specific situation and anatomy, where there is a residual gradient and an aberrant right subclavian artery, which the interventional cardiologists did not want to jail. After testing, it became clear that the best stent was actually one that had a size between 16 and 18 millimeters. So they could assess using computational models what was the flow in the right subclavian artery and the stress on the wall. I move on. Patients with single ventricle physiology who are palliated with Fontan procedure often go to a cardiac MRI examination. As we can see, there is a very large anatomical variation, but they all have a common final surgical pathway, which is that of the lateral tunnel or extracardiac tunnel in the most modern, with the most modern technique. What MRI can do, besides assessing for volumes and function and latency of the pathways, we can also look and calculate the collateral flow, which is omnipresent in this patient and contributes to either between 9 and 49% of the total pulmonary venous return. At least 1/3 of this patient has at least 30% of collateral flow. 80% of this comes from venous collateral, which on CT are not visible. I'm not going through the diagram here, but if there are questions at the end, I'm happy to answer them. It is just utilizing formula and obtaining information in the region of interest in the pulmonary artery and the pulmonary vein that we get those information. If we use 4D flow, it's a single acquisition, and then we place our region of interest where we want, SVC, IVC, right-sided pulmonary vein, and so on, and we can calculate our collateral flow. 4D flow can be used also to assess diastolic function because we obtain flows information through basically every single portion of the heart. So in blue, there is the flow through the AV valve, which shows a normal EA ratio. Whereas in green is the flow through the pulmonary vein that shows a predominant flow in diastole, which indicates diastolic dysfunction that was present in this patient. As you know, Fontan patients are prone to clot in the Fontan circuit. These are better seen on CT, and these are CT images that shows a clot in the lateral tunnel and in the branch pulmonary arteries. And you just look at the arrows.
Dr. Alessandra,
yeah?
you have 2 minutes to go, please, for the shortage of our time. Thank you.
Sure. And then we look at the clot source in the left pulmonary artery. To do that, it's important to know how to run the images and to avoid strict artifacts and to avoid particularly misunderstanding of the images. I suggest a later venous phase about 2 minutes after contrast injection. Patients with Marfan syndrome might require surgery for the dilated aortic root. We tend to do this using the PERS technique, and the CT is the best imaging modality for us because this is the protocol that we use. We send the information to the manufacturer to obtain the prostheses that are wrapped around the aorta on a beating heart. CT, as I said, also for anomalous coronary arteries, although they can be identified on MRI, but the anatomy is better seen on a CT. However, MRI can be helpful for stress analysis, like we see in this patient. We tend to use the glutamine stress MRI. In this case, the patient wasn't under ECG, went through a perfusion MRI scan, which actually was positive with a small area of inferior scar in this patient who underwent unroofing. And finally, as I move to the end, vascular rings are better seen on CT. We can look for pulmonary arteries link. We can look for the effect of pulmonary venous occlusive disease in the lungs. So we have information on the lung parenchyma as well on cardiac CT, which might be helpful in guiding patients' management. And with this, I conclude saying that MRI and CT are essential too for diagnosis, follow-up, and treatment planning in patients with congenital heart disease. It's key to know the clinical question and the cardiac anatomy and what sequences we want to use if we use MRI. If we use CT, we have to be carefully planning the CT to minimize the radiation burden. And and answer the clinical question, and often there is more than one. Be aware of what are the limitations of each imaging modality and the available alternatives. And the data have to be reproducible and the measurement standardized so that we can guarantee an adequate longitudinal follow-up and optimal decision making. And finally, last but not last, the approach to this patient is multidisciplinary, multimodality, and we value the collaboration with radiologists, interventional cardiologists, surgeons, and the whole team. Thank you.
Thank you. Thank you, Dr. Alessandra, for this nice, comprehensive presentation. And we hope to see you in Jordan on our next meeting. Thank you very much.
Thank you very much. Thank you for the invitation. Bye-bye. Enjoy the morning.
Thank you. We will go coffee break now. Thank you.